Welcome back to the deep dive. Today we're shifting gears pretty significantly.
We are.
We aren't just exploring a medical topic for, the sake of intellectual curiosity. We are stepping directly into a high-stakes simulation. I want you to close your eyes for a second, unless you're driving, of course. And just picture this. The air conditioning is humming. The room smells faintly of antiseptic. Your palms are a little bit sweaty.
Oh, I know this feeling.
And you're standing in front of a long table covered in equipment. Across from you is a stern-faced examiner with a clipboard looking over their glasses at you. You are a postgraduate student, and this is the Gujarat University MD anesthesiology exam.
It is a scenario that strikes fear into the heart of even the most prepared resident. And today, I'm stepping into the role of that senior faculty mentor.
Okay.
We're going to strip away all the noise. We're not just chatting about plastic and rubber components.
Right.
We are identifying the high-yield material. My goal today is to focus on what the examiners actually want to hear versus the mistakes that will cause you to fail immediately.
And we are looking at the absolute bread and butter of the specialty today. The triad. Face masks, airway adjuncts, and nebulizers. Now, to the uninitiated, these might seem like simple entry-level items, but in an exam context, they're landmines, aren't they?
They absolutely are. There's a saying we have in the faculty, you can fail a candidate on the basics faster than on the complex stuff.
Wow.
If you can't explain the physics of a nebulizer or the precise anatomical sizing of a Guedel airway, I can't trust you to manage a difficult airway in a crisis.
That makes sense.
These devices are the fundamental interface between the anesthesiologist and the patient. So, failing to answer basic airway equipment questions is often considered a killer mistake in the Viva voce.
Okay, that sets the stakes properly. Let's dive right into Part A, face masks. And let's frame this exactly as it happens in the exam.
Let's do it.
When a student picks up a face mask and a Viva, what are they actually holding in their hands?
They are holding the Lifeline.
The Lifeline.
That's how you should think of it. You need to define the face mask not just as a piece of plastic, but as the fundamental interface between the anesthetic machine's breathing system and the patient's respiratory tract. It is the first line of defense in airway management.
And it has this dual nature, right? It's not just for putting people to sleep for surgery.
Correct. You have to conceptualize the scope of usage immediately. We use it for perioperative anesthesia induction, maintenance for short cases, emergence.
Sure.
But equally important is its role in emergency resuscitation. Every resuscitation begins with a mask. If you can't mask ventilate, everything else becomes exponentially harder. In the exam, you need to articulate that duality right away.
So let's say I'm the student. I pick up this device. What questions are you, the examiner, going to fire at me immediately?
The classic opener is deceptively simple. Pick up this device and tell me what it is.
Okay.
And that is a test of your precision. Don't just say it's a mask.
Right.
It's an anatomical, transparent, disposable anesthesia face mask. Then I'll ask you to demonstrate the hold. And finally, I'll ask, what are the complications of long-term masking? That's where we separate the novices from the experts.
Okay, let's get into the weeds of the design then. This is the very high yield section. We see these masks every day, but we rarely look at them this closely. What are the key components we need to list out?
This is a favorite Table Viva question, so you need to break it down into 3 distinct parts. First, the body. In modern practice, this is almost always transparent plastic.
Why is transparency so non-negotiable? Is it just like an aesthetic thing?
Not at all. It is crucial for safety.
Okay.
You need to see if the patient regurgitates. Seeing vomitus or blood immediately allows you to react suction, head down, kilt. It also lets you see condensation,
Which is a sign of breathing.
a primary sign of exhalation.
Yeah.
If the mask is black rubber, which, you might still see in a museum or a very old kit, you're flying blind. You miss the breath, you miss the vomit.
Okay, so we have the body. What's next?
The seal, or the cushion. This is usually a high-volume, low-pressure, air-filled rim.
High volume, low pressure.
Right. Its job is to mold to the different facial structures. High cheekbones, sunken cheeks in the elderly, or edentulous patients. It makes the fit airtight. And then, crucially, the connector.
The connector seems pretty standard, but I bet there are specifics about the sizing that we need to know.
There are, and these numbers are non-negotiable for the exam. It's a standard 22mm female connector.
22mm female.
Yes, designed to fit the breathing circuit Y piece or the angle piece. Now, if you pick up a pediatric mask, you might see a 15mm male connector instead.
Oh, okay.
Knowing those dimensions, 22mm female, 15mm male, it just shows you pay attention to detail.
I've also noticed these little colored rings or hooks around the connector on some masks. What are those for?
Ah, good question. Those are retaining hooks. They're for the spider head strap or what's called the claws and harness.
The claws and harness.
Yeah. If you're doing a case where you need to keep the mask on for a long duration without holding it, say a short procedure where you need your hands free, or during pre-oxygenation in a difficult patient, you hook the strap there. It distributes the pressure evenly.
Now, here's a concept that always seems to trip people up. Dead space.
Yeah.
We talk about it all the time, but how does it apply to the mask specifically?
This is vital, especially when you talk about pediatrics. The mask itself constitutes mechanical dead space. That's the volume of gas that is rebreathed without taking part in gas exchange.
Right.
In an adult, the volume of the mask is pretty negligible compared to their tidal volume. But in a neonate or a small child, a large adult mask represents a massive increase in dead space.
Because their own tidal volume is so small to begin with.
Exactly. If the dead space of the mask exceeds the child's tidal volume, they are just breathing their own CO2 back and forth.
Which is obviously bad.
It's very bad. That is why, for kids, we use rendezvous masks or specific minimal dead space masks to prevent CO2 retention. In the exam, if you mention mechanical dead space when discussing pediatric masks, you are scoring very high marks.
Moving on to functions then. We mentioned pre-oxygenation. In the exam, if they ask about the function of the mask, that's probably the first thing to mention, right?
Absolutely. It's the process of denitrogenation. You're using the mask to create a tight seal and replace the nitrogen in the functional residual capacity with oxygen.
It buys you time.
It buys you safety time during apnea.
What about that patient who's panicking? The claustrophobic patient who tries to fight the mask off?
That's a great practical Viva question. You don't force it down on their face. That just spikes their catecholamines. You use the hovering technique.
Hovering, okay.
You hold the mask close to the face to enrich the local atmosphere with oxygen without actually touching the skin, at least until they're sedated enough to tolerate the seal.
And then, of course, there's assisted or controlled ventilation.
Yes, the concept of positive pressure ventilation, or PPV. This is where the seal becomes king.
Right.
If you don't have a seal, you don't have pressure. Simple as that. And finally, anesthetic delivery. We use the mask to deliver volatile agents like sevoflurane.
This brings us to the complications. You mentioned earlier that nerve injuries are a high-yield topic. So if I'm holding the mask too tight, what am I actually damaging?
We call this the three-finger trap, or rather the consequence of doing it wrong.
Good.
When you hold the mask, you use the CE clamp. Thumb and index finger form a C on the mask.
Right, on the body of the mask.
While a middle ring and little fingers form an E on the mandible, on the bone.
And if you let those fingers wander...
If your fingers press into the soft tissue rather than pulling up on the bony ridge of the mandible, well, first you're compressing the airway. But specifically for nerves, if you press too hard at the angle of the jaw or the body of the mandible, you can compress the mental nerve or branches of the facial nerve.
And what does that lead to?
Lower lip weakness. Or if you compress the buccal branch, you get difficulty controlling saliva or speech postoperatively. It's embarrassing for the anesthetist and very distressing for the patient. Imagine waking up from surgery and drooling uncontrollably because your doctor squeezed your face too hard.
Not a good outcome. What about the eyes? I've definitely seen residents get scolded for letting the mask slide up.
Ocular injuries are unfortunately common. If the mask rides up the bridge of the nose, it can press on the globe. This can cause a vagal reflex, slowing the heart rate, or even, in extreme hypotensive cases, central retinal artery occlusion.
Wow.
But more commonly, it's corneal abrasions. A finger slips, or the mask edge itself rubs the cornea. That's why we emphasize taping the eyes shut before you really get to work.
There is one more big complication I want to touch on for masks. Gastric insufflation. There's a rule of thumb here regarding pressure, isn't there?
The 20-centimeter H2O rule. This is critical exam knowledge. You have to know it.
20 centimeters of water.
Right. The lower esophageal sphincter, the LES, its opening pressure is roughly 20 centimeters of water. So if you're masking a patient and you're squeezing that bag with all your might, generating pressures of 30 or 40,
You're blowing past it.
you're forcing air straight into the stomach.
Which essentially turns the stomach into a loaded gun for aspiration.
Precisely. A stomach full of air is a recipe for regurgitation. So the examiner wants to hear you say, I will maintain airway patency with adjuncts to allow ventilation at pressures below 20 centimeter H2O.
Perfect transition. You mentioned airway adjuncts. Let's move to Part B, airways.
Right, and we need to distinguish these terms immediately for the exam. We're talking about airway adjuncts here, oropharyngeal and nasopharyngeal airways.
Right, these are helpers.
They are not definitive airways. A definitive airway is a cuff tube in the trachea. These are just helpers.
And what is their primary mission?
To lift the tongue and the epiglottis away from the posterior pharyngeal wall. That's it.
Because in an unconscious patient,
In an unconscious patient, muscle tone is lost, the tongue falls back, and it obstructs the glottis. These devices mechanically stent that space open.
I've heard this described as an artificial cough. Is that fair?
In a way, yes. By establishing a patent conduit, they obviously allow for airflow, but they also provide a path for suction catheters. If a patient can't cough up secretions, you can pass a suction catheter right through a Guedel airway to clear the pharynx.
Let's focus on the oropharyngeal airway, the Guedel airway. This is a superstar of the exam table.
It is.
If I pick this up, what are the design specifics I need to point out?
Okay, so it has a flange at the proximal end to stop it from falling into the mouth.
Makes sense.
It has a reinforced bite block, that's the hard section, which prevents the patient from biting down and occluding the tube itself.
Mm-hmm.
And it has a curved body that is designed to match the anatomy of the hard and soft palate.
Okay, sizing. This is the #1 exam question I hear. How do I size a Guedel airway? And I know there's some debate here.
Do not get this wrong in the exam. The method is to measure the distance from the center of the incisors or the center of the mouth to the angle of the jaw, the mandible.
I've definitely seen people measure from the corner of the mouth to the earlobe. Is that just wrong?
It's an alternative method found in some texts, but it's generally considered less accurate anatomically. For the exam, stick to center of incisors to angle of jaw. It is the gold standard answer.
And they're color-coded.
Yeah.
Do I need to memorize all the ISO standards?
You don't need to memorize every single manufacturer's variation, but you should absolutely know the standard adult sizes. Green is size 2, which is 80 millimeters.
Okay.
Orange is size 3, 90 millimeters. And red is size 4, 100 millimeters. The examiner might hand you an orange one and ask, who is this for? You'd say, this is a medium adult size.
Insertion technique is another place where I've seen students fumble.
Yes. The classic technique for adults is the 180-degree turn. You insert it upside down with the concavity facing the roof of the mouth.
Okay.
As it passes the soft palate, you rotate it 180 degrees so it sits correctly over the tongue.
And why do we do that rotation? Why not just slide it in?
Because if you just slide it in following the curve, you will push the tongue backward into the pharynx, which causes the very obstruction you're trying to solve. The rotation acts like a scoop to lift the tongue forward. However, in pediatrics, we do not use the rotation method.
Why the difference for kids?
Because the hard and soft palates in children are much more friable and can be damaged by that hard plastic rotation.
Well, what do you do?
In kids, you use a tongue depressor to hold the tongue down, and then you just slide the airway in directly.
Indications and contraindications.
Quick and dirty.
Indication. Unconscious patient. Contraindication.
Yeah.
Awake or semi-awake patient. If their gag reflex is intact, putting a Guedel in is just a recipe for Lanner spasm or vomiting.
Which brings us neatly to the nasopharyngeal airway, or NPA.
The NPA is a different beast altogether. It's soft. It's malleable rubber or plastic. It has a bevel at the tip and a flange or sometimes a safety pin end to keep it from getting lost in the nose.
How do we size this one? Length is key here. You measure from the tip of the nose to the tragus of the ear.
Tip of nose to tragus.
Right. Some texts add +1 inch, but tip to tragus is the standard answer. For diameter, you can estimate using the patient's little finger or just the size of the nostril.
And insertion.
Lubrication is non-negotiable. Lidocaine jelly is best. You insert it perpendicular to the face, straight back along the floor of the nose.
Not up.
Not upwards towards the brain. And you want the bevel facing the septum to avoid catching the turbinates, which can cause some nasty bleeding.
Let's talk about the contraindications. Right. There is a specific trauma scenario where an NPA is absolutely, completely forbidden.
Base of skull fracture. Full stop.
Right.
If a patient has raccoon eyes, battle sign behind the ear, or CSF rhinorrhea, that's fluid leaking from the nose, you do not put anything in the nose.
I can imagine why.
There are horrific case reports of NPAs entering the cranial vault. If you suggest an NPA in a head injury station without ruling out a base of skull fracture, you will likely fail that station. It's a critical safety issue.
That is a critical safety point. So comparing the two OPA versus NPA, this is the classic exam table summary question. If I can only pick one, which do I choose?
It depends entirely on the GCS, the Glasgow Coma Scale, and the patient's reflex status.
Okay.
The NPA is the truce maker. It's much better tolerated in lighter planes of anesthesia or in semi-conscious patients. The OPA requires deep suppression of reflexes.
And the trauma profile is different as well.
Right. OPA risks damage to teeth and lips. NPA risks epistaxis nosebleeds and adenoidal trauma. If you have a coagulopathic patient, someone on blood thinners, you probably want to avoid the nasal route if possible to avoid an uncontrolled nosebleed.
Excellent. Let's move to Part C, nebulizers. This feels like a shift from plumbing to physics.
It is, really. A nebulizer is a device that converts liquid medication into a mist or an aerosol for inhalation.
And why do we care as anesthesiologists?
Well, this matters for intraoperative bronchospasm, for ICU ventilation, and for treating things like post-extubation stridor.
Okay, let's break down the types. This is high yield for the physics portion of the Viva, right?
Very high yield. You have three main players. First, the jet nebulizer. This operates on the Bernoulli principle.
Bernoulli.
Yeah.
Can we explain that simply for the listener? I know students often just parrot the definition without really understanding it.
Sure. Imagine a garden hose. If you put your thumb over the end, the water speeds up, right?
Right.
Bernoulli's principle just states that as the velocity of a fluid or a gas increases, its pressure decreases.
Okay.
In a jet nebulizer, a high-velocity jet of gas, usually oxygen at 6 to 8 liters per minute, passes through a narrow orifice. This creates a low-pressure area right next to the jet.
And that low pressure does what?
That low pressure sucks liquid up from the reservoir tube. When the liquid hits that high-speed gas jet, it shatters into tiny droplets against a baffle, and that creates the mist.
That's very clear. Velocity up, pressure down, liquid gets sucked up. Okay, then we have ultrasonic nebulizers.
These use a piezoelectric crystal. It vibrates at a very, very high frequency, creating standing waves in the liquid that break the surface tension and form droplets. They're very efficient, but they have a major downside. They can heat the solution.
And why does heat matter in this context?
If you're nebulizing proteins or certain other sensitive medications, heat can denature them. It can destroy the drug, rendering it ineffective.
And finally, the mesh nebulizer.
This is the modern standard, the kind you'll often see in ICUs. It uses a vibrating mesh with thousands of microscopic holes to push liquid through. It's quiet, very efficient, and has a very low residual volume, which means you don't waste much of the drug.
What are the main clinical uses we need to list?
Bronchodilation is number one, salbutamol and ipratropium for asthma and COPD.
Of course.
Then vasoconstriction using nebulized adrenaline for post-extubation stridor or croup. Mucolysis using acetylcysteine. And simple humidification using sterile saline to loosen secretions.
Anesthetic implications. How does this fit into our daily workflow?
Pre-op, we use it to optimize the wheezy COPD patient. Intra-op, we can connect nebulizers to the breathing circuit using a T-piece.
Is there a catch to that?
There is. Here's a practical tip. Nebulizers can cause rainout or condensation in the circuit. This water can make the expiratory valve sticky or even flood the flow sensors. You have to watch out for that.
And deep extubation. I've heard of this.
Yes, nebulized lidocaine. It's a great trick to blunt the airway reflexes right before you pull the tube, which can give you a much smoother emergence from anesthesia.
What about the limitations? I mean, it's not a perfect delivery system.
Oh, far from it. It's incredibly inefficient. Only about 10% of the drug actually reaches the lower airways.
Only 10%.
Yeah. The rest is lost in dead space. It rains out in the tubing, or it's just exhaled into the room.
And there's a specific complication involving the eyes again, isn't there?
This is a classic caught-out moment in the Viva. If you are nebulizing Ipratropium, which is an anticholinergic drug, with a face mask that fits poorly, the fugitive aerosol can escape into the patient's eyes.
And what happens then?
It causes Mydriasis dilated pupils. So imagine you're in the ICU, the patient has had a nebulizer, and suddenly one of their pupils is blown.
You'd think it's a neurological event.
You'd think they are having a stroke or some major neurological event, but it's just the nebulizer mist affecting the eye. Always, always check the mask fit.
That is a fantastic clinical pearl. Let's move to Part D, exam integration. We've covered the facts, but how do we package this for the past?
We need to talk about Viva traps. These are the holes that students constantly fall into.
Okay, trap number one.
Confusing an airway adjunct with a definitive airway. I cannot stress this enough.
Right.
If the examiner asks, is the airway secure, and you say, yes, I have a Guedel in, you have failed. Only a cuff tube in the trachea is definitive.
Trap number two, sizing.
We covered this, but it bears repeating. If you
Right.
measure the OPA on the cheek instead of the angle of the jaw, the external examiner will stop you right there. It shows you're just mimicking what you saw on TV rather than what you learned in anatomy.
And the Venturi mask. We didn't touch deeply on this in the mask section, but it comes up in the exam constantly.
Right. The Venturi mask is a high-flow device. You absolutely need to know the color coding. This is rote learning, I'm afraid. Blue is 24%.
Okay.
White is 28%. Yellow is 35%. Red is 40%. Green is 60%.
Is there a mnemonic or a trick?
I just remember blue is 24 and work my way up.
Yeah.
But the deeper question is the principle. It uses the principle of air entrainment.
So it's Bernoulli again.
It's Bernoulli again. The oxygen flows through a narrow orifice, creating that pressure drop, which then entrains a specific fixed ratio of room air through the side ports. It guarantees a fixed FiO2 regardless of the patient's respiratory pattern. That is the key difference from a simple face mask.
And if I have to draw this?
Yes. For a 20-mark theory answer, you need diagrams. For the Venturi, you draw a tube with a narrowing orifice, the jet and big side holes, the entrainment ports. You show arrows of air being sucked in.
And for the Guedel?
Sketch the side profile of a face. Mark a point at the incisors and a point at the angle of the jaw. Draw a double-headed arrow connecting them. Label it correct sizing. It's simple, but it scores marks.
Structure is everything in a written answer.
Always. You must follow the standard medical hierarchy. Definition, classification, indications, contraindications, complications. Never, ever start with complications. If I ask you about Guedel Airways and you start with, well, it causes vomiting, you're starting on a negative. Start with, it is a hollow oropharyngeal device.
Expert advice indeed. Let's wrap this up with a summary. What are the key takeaways for the exam?
Okay, recap time.
Let's hear it.
For masks, the seal is king. Without a seal, you have nothing. And watch the eyes and the nerves, you have to protect them.
Got it.
For Airways. Guedel is for the unconscious, MPA is for the sort of awake, but you have to watch out for base of skull fractures. And size matters. Know your landmarks.
Okay.
For nebulizers, it's the Bernoulli principle. And watch for eye contamination with anticholinergics.
And in the exam room?
In the exam, handle the equipment with confidence. Don't fumble. Pick it up, look at it, check the size before you pretend to insert it in the dummy. Show them you know what you're doing.
It really means preparation is key. You can't just wing the basics.
Exactly. The airway is the anesthesiologist's religion. These are your ritual instruments. You need to know them cold.
Thank you, senior faculty. That was a masterclass.
My pleasure. Now go practice.
And to you, the listener, listening is great, but tactile memory is better. Go to the skill lab. Pick up the green Guedel. Flex the rim of the mask. Visualize those Venturi ports. Make your hands learn what your ears just heard.
Good luck with the exam. You've got this.
See you on the next deep dive.